Assalamu alaikum. Starting the long clinical consultation day, Miss Julia, 25 years, with complaint of headache. We'll start in seconds. Are you ready, Dr. Sarah?
Okay.
Yes, here you go.
Hello, my name is Dr. Abdullah. I'm one of the medical doctors in the clinic today. Can I confirm you are Ms. Julia, 25 years old?
Yes, doctor.
Okay. Can you tell me what brought you to our clinic today?
Yes, doctor. I have headache. So annoying headache, doctor.
Okay, I'm sorry to hear that. So let us discuss more about this issue, and I will take some notes. Be sure that it will be confidential, okay?
Okay.
Can you tell me when this headache started?
Actually, doctor, it started 1 month back. When I went to my GP, he gave me some painkillers. Then the headache little bit improved. However, it comes back, and I cannot tolerate the headache, doctor.
I'm sorry to hear that. This is the first time it happens?
Yes, doctor.
Okay. And you told me it's worsening over this last month, right?
Yes.
Can I ask you what seems to make this headache worse?
I noticed, doctor, whenever I cough or sneeze, I feel the headache is much worse.
I'm sorry to hear that. And it gets better with these painkillers, right? You told me partially.
Actually, doctors, for some time only, then it comes back.
I'm sorry to hear that. Okay. Can I tell you if it has specific, this headache will come specific time of the day?
No, I notice no particular time for that.
Okay. Where is exactly in your head the headache?
Yeah, all over my head. And it was whenever I bend forward, or as I said to you, when I cough or sneeze.
Okay. Can you tell me it has specific character, this pain?
Yes,
Or
it's it's dull aching.
Okay. Can you tell me how much it is the severity from the scale on the scale 1 to 10?
Yeah, it's 7 to 8.
And it is going anywhere, this pain?
No, doctor, it's all over my head.
Okay. Can I ask if you had any trauma on the previous month or
No, doctor.
all right. Any neck stiffness?
No, but whenever I also move my neck forward, it might worse the headache.
Okay. Can I ask you if this is worse with hot baths?
No, doctor, it's not.
Can I ask if you have any problem with your vision, with your eyes?
Yes, doctor, I noticed my vision blurry recently.
Okay. Any problem with the side vision when you feel yourself you are hitting on side objects?
No, doctor, but sometimes I feel double vision.
Okay. And this double vision, is it painful or
No,
it's
no,
okay?
no, it's not.
Okay. Any problem with your consciousness or your memory?
No, it's fine, doctor.
Any shakiness of your hands or your body?
No, doctor.
Any muscle weakness
No.
or abnormal sensation or numbness?
No.
Any abnormal gait?
No.
Any problem with the hearing, smell, or
No.
hearing or smell? Any problem with your speech?
No.
Okay. Um, all right. Can you tell me if you had any fever?
No,
Uh, any weather preferences?
no,
Any weight changes?
no, doctor. It's the same since before.
So how okay, how much is I'm sorry to ask you, how much did you maintain your weight at?
Yeah, I think my doctor, when he weighed me, he told me that my body mass index around 32. Yes, like that.
And it has been maintained all over the uh,
Yes.
previous months or years. Okay. Any lumps or bumps in your body?
No,
Any joint pain?
no,
Uh, any back pain?
no,
Any eye changes other than the blurry vision, like
no,
painful eye? Okay. Um, any problem with your urine or water works?
no, doctor.
Any problem with the bowel?
No.
Uh, okay. Can I ask you? You told me that you don't have any weather problem and you don't have any bowel changes, right?
No,
Um, any change in your size of your hands and or feet?
no,
Um, any? I'm sorry to ask you this private question. Any like nipple discharge or milk discharge from your nipples?
no.
Okay. Can you tell me? I will ask you some private questions. Can you tell me? Are you married or with partners, Junior?
Uh, Actually, doctor, I am not in a relationship.
All right. Are you using the pill?
Uh, what pill, doctor, you mean?
The one to control
Yeah, yeah, yes, doctor. Yes, actually, yeah, because yeah, I'm still young, doctor. I don't want to have pregnancy. I'm not planning for any break because also I don't have any uh partner.
okay. So any previous pregnancies
No,
and no previous miscarriages, right?
no.
Uh, okay. Can I ask you if you had any past problem in your health?
Um, Generally, doctor, no, it's not something general. I mean, just some. I had a problem with since I was in the teenager till now. I have problem with acne, doctor, in my face.
Okay. Have you received any like medication for this acne?
Yeah, doctor, a lot of medication. You can see the list I'm taking with antibiotics. I use some topical medication and a lot of things I tried, but still, doctor, I have this problem.
Okay. Uh, can you show me your drug list?
Yeah, there is antibiotics, tetracycline. Also, there is vitamin A, retinoid.
Okay.
Yeah, this is the medication.
Okay. Any surgeries before? Any admissions at the hospital?
Yes, doctor, I tried the laser to my acne as well, but also it didn't help.
Okay. Any other surgeries you have?
No, doctor.
Any problem? Any health problems in your family?
With my
Your family?
no, doctor.
All right. Can I ask what's your job, Mrs.
You
Julia?
mean yeah, you mean my family history of the same problem? Yes, doctor. My mother was having migraine.
Okay. And this migraine, she has been diagnosed with it and having
Yeah,
medication.
yes, doctor. She's diagnosed with migraine and she's taking medication called triptan.
And she's well with this medication,
Yeah,
right?
she's on controlled with this. Yes.
Okay. And can I ask what's your work, Mrs. Julia?
Yes, I'm still the student, doctor.
How is this problem affecting your studies?
Yeah, doctor, the headache is too much annoying.
I'm sorry to hear that. We will try to help you, Mrs. Julia.
Okay.
And are you smoking?
Yes.
I would advise you to stop smoking as it can be bad for your health.
Okay, doctor.
Is it okay? Okay. Well, are you drinking alcohol?
Yeah, socially, doctor.
Okay. Um, are you driving, Mrs. Julia?
Yes, my own car.
Sorry, I would advise you because of this problem with the vision, this blurry vision. It's better to stop driving now, Mrs. Julia. Miss Julia.
Okay,
Um, okay. Um, can I examine you?
sure, doctor.
Okay. I will start first with the eyes. Can I check the visual acuity?
Visual acuity is normal. She can
Uh,
see, but there is little um impairment with the small letters. If you show her the chart,
the chart. Okay.
she
Visual.
feel blurred. Yes,
Okay. Uh, visual field.
yes. Visual field intact, not affected.
All right. Eye movement.
There is lateral double vision in the left eye. I mean diplopia to the left.
Uh, okay. And how about the accommodation?
Intact.
So the diplopia only on the left
Yes.
side. What if she covers? What if she covers the left eye?
Yeah, still she can't.
All right. She after covering the left eye,
Yeah, they
anyone
disappear. Of course, disappear. Yes, you cover the diplopia or the affected eye.
and okay, the diplopia will disappear.
Yeah, disappear when she cover. Yes.
Okay. Can I examine the fundus
Yes. You notice that there is papilledema
bilaterally?
bilaterally. Yes, both disc swollen.
Uh, okay. Can I examine the blood pressure?
Blood pressure is 130 over 80.
The pulse?
Normal.
Any proximal myopathy?
No.
Sorry, the eye has any other changes rather than the examination we
No.
had,
No.
like pallor or okay.
No.
Any mouth changes?
No. There
Uh,
is acne in the face.
yes. The acne in the face.
Yeah, some of them nodules and yeah, all it change you can notice in the face.
All right. Sorry, Mrs. Julia, do you have any problem with your periods?
No, doctor,
Is
it's
it
fine,
regular?
regular.
Okay. Can I check the neck? Any swelling?
No, 2 minutes left.
Okay. Um, okay. Can I examine if there is any neck stiffness?
It's somehow there is some neck stiffness.
Okay. Um, can I do rapid like motor assessment of the upper and lower limbs
Yes, intact,
and sensory
intact,
coordination?
intact.
Okay.
1 minute left.
Okay. Um, can I ask what's your concern, Mrs.
Yeah,
Julia?
doctor. What I have is it migraine like my mother.
So, after examining you, Mrs. Julia, and after taking full history from you, I think that you have problem with the pressure inside your brain. I think it is. We have something called increased intracranial pressure. Don't mind the medical name. With this, this leads to increase the pressure inside of your brain, and it will lead to the headache that you have. I think it can be related to the medication that you're receiving for the acne. Any other concerns?
Is it curable, doctor?
Um, it, it's not it's not curable, but it's manageable. We
Yeah.
will have to stop your treatment for the acne, and we will refer you to the
Okay.
doctor.
Time is up.
Mm.
Well done, Dr. Sarah. Yes. You catch it at the end. Well done. Okay. Can present your case.
So I think Mrs. Julia, after examining her and taking her history, I think she has increased idiopathic increased intracranial pressure, and this increase this idiopathic increase in intracranial pressure is worsened by her acne medication, especially the retinoids. Um,
What's your differential diagnosis?
because of the and because of the short history of the headache, we have to exclude other causes, especially that he has some neck stiffness. We have to exclude other causes like subarachnoid hemorrhage, like cerebral venous thrombosis. But again, this is it has been for 1 month. I think the subarachnoid hemorrhage and the cerebral venous thrombosis, it has to be on shorter duration. Also, we have to, because the patient also has babble edema, we have to exclude other like uh, tumors inside of the brain, like pituitary tumors or other primary or secondary tumors.
How you investigate this patient?
So after basic investigation, CBC, kidney function tests, liver function test, I would run urgent CT brain for her to exclude the emergency, like emergency causes of increased intracranial pressure, like subarachnoid hemorrhage or like cerebral venous thrombosis or tumors. And also, I would do lumbar puncture to measure the pressure of the to measure the pressure and to confirm the diagnosis of idiopathic increased intracranial pressure. And
Okay.
also, and also,
will you do invasive tests on this patient? Hello?
yes, I don't. I'm just trying to check.
Okay. Will
The
you do?
lumbar puncture, but
Yes, exactly. What's the benefit from checking the or doing lumbar puncture?
so lumbar puncture has two benefits. First of all, we will measure the pressure of the pressure of the CSF, and also we will take CSF sample to exclude other like infection or like MS, and also it will be useful in I think we need to do it also emergency, as an emergency can be, to reduce the intracranial pressure.
So you mean diagnostic and therapeutic?
Diagnostic and therapeutic.
Okay, what else?
I think we have to run, because of this short history, I think we have to do also thrombophilia screening. If the CT is showing cerebral venous thrombosis, and also maybe we need to do hormonal assay, especially that she has acne that's difficult to treat. Um,
Okay. How you manage this patient?
so, first of all, non-pharmacological management,
Mm-hmm.
like patient education, patient counseling, multidisciplinary team referral. We will refer to the neurology doctor, the neurosurgery, and the ophthalmology. And we will need to do, as I said, we have to do urgent lumbar puncture to relieve the pressure, especially that she has blurring vision and papilledema. And uh, then we have to ask her to stop the acne medication,
Mm-hmm.
and also to stop the pill, the oral contraceptive pill, and then to refer her to the dermatologist and the gynecologist to get further like management for these issues.
Okay.
Then the long
Any pharmacological therapy,
I think they're sorry, the maintenance therapy that we can give acetazolamide.
Exactly, yes.
Acetazolamide, yes.
Okay. What other invasive procedure or surgery can be done?
If the lumbar puncture is not
Yes. Recurrent lumbar puncture. Yes.
we can do recurrent lumbar puncture.
Okay.
Some severe cases we can do ventricular uh,
Excellent.
peritoneal urgencies.
AV patient. Yes.
Yeah.
And optic nerve fenestration. Sometimes.
Yes. Times the administration.
Okay. Yes, this is the case.
Ah,
You did it well, Dr. Sarah. Thank you.
thank you so much.
Yeah, well done. I know it's difficult little bit because it's not frequent topic, but yeah, it might come. Let's talk about the headache itself as a complaint from the beginning. We have to screen first the commonest cause after analyzing the complaint. You can put differential for the headache, especially those common type in the exam, like head tension headache. You can put it in a differential and you can ask one question for tension headache. Is it band-like? And is it triggered by stress? This is for tension headache, and you can put tension headache as differential for any headache, especially for subacute headache for more than 1 or 2 weeks. However, the tension headache will not increase the intercalated pressure or will not have the signs of increased intercalated pressure, but we can say to the examiner that it's against that. Okay, so this is the commonest headache in exam. The other second differential and common in the exam, the migraine headache, especially the females. And you can also rule out this headache by the character of the headache. It's not pulsating one, it's not in one side, so it will be rolled out. Just to show the examiner that you are screening the commonest cause of headache in the patient. Finish the migraine, you can go to other possible cause, which is medication overuse. It will be also for subacute or chronic use. And you can screen for the medication which the patient is taking, for example, the painkillers. I give you that I am taking the medication. You can ask me how frequency I'm taking this medication, just to be sure that it's not the medication overuse headache. The other types of headache like cluster, it's not characteristic here because the patient will have lacrimation and redness in the eye, and it will be localized more to the eye. Other causes, as you said, cerebral venous thrombosis, meningitis, subarachnoid hemorrhage, but those will be coming as acute. But our patient here is considered as subacute to chronic. So what you screened for was great because you are screening, but even you didn't reach to diagnosis, still you're calm. You try to collect your thought till the end. And the most important clue in this patient, the body mass index. When I told you my body mass index is high, more than 25 or 32, so the obesity, one of the possible causes of that. Of course, you have to rule out the alarming signs of headache, which is increase in intracranial pressure. Is it worse while leaning forward, worse with the sneezing, any weakness, any pins and needles? You ask all these questions. After that, you try also to screen for acromegaly cause and pituitary adenoma as a cause of headache. However, you will have the other signs in like large hand, change the ring size, change the foot size. All this will be clue for the patient scenario if you have like this scenario. Good question. Also, they ask about the nipple discharge for prolactinoma. And you might also find Cushing, any pituitary adenoma signs and symptoms, but not in this scenario. Apart from this, the other system review will go smooth, nothing will be positive. Apart from the female history, you will find OCPs, you might have also pregnancy. This is the possible cause in female in the middle age, and taking some medication for acne like tetracycline, like retinoid, vitamin A. All this reason will be steroid as well, also one of the reason for the idiopathic intracranial hypertension, plus the obesity. Whenever you have these signs and finding, you should put in your mind the top as you did intracranial, idiopathic intracranial hypertension. Alarming sign will be negative here, apart from the weight, but it's not gaining weight. She is obese from the start. Family history, just to distract you about migraine. The smoking, alcohol, all this should be stopped. And the driving, as you did, we have to stop driving as long as she has double vision or diplopia. In the examination, I prefer to start by the body mass index. Again, confirm to the examiner that you noticed she is obese and her body mass index is above the normal level. Then the vitals, then go to the eyes. As you did full eye examination, which is perfect in this patient. Starting by acuity, fields, reflexes. You can do also the reflexes and its shape, and ended by fundoscopy for papilledema. You will have papilledema, of course. This is one of the pathognomic finding in this patient. Apart from this, the acne in the face, plus the medication list, you can find the medication mentioned in the scenario. The differential, as you said, idiopathic intracranial hypertension. I can put tension headache, but again, it's tension headache, no, the character of the headache, but still it's one of the commonest cause of headache in the exam and in the people. Migraine, you can add, but against that, especially with family history, against that, the character of the headache as well. And the last, yeah, I think this is enough. If you want to add meningitis, but against meningitis, also the patient will have, it will be as acute, not for 1 month. So against that, also the onset of the headache. Okay. This is the case. You did well, Dr. Sarah. If anyone has comment or if you have question, Dr. Sarah, you can ask. If you have comment, you can tell any added information. Okay, you wrote the scenario. Good. 35-old female, Lisa with leg swelling. Okay. Please, anyone has comment or question, he can write down, or he can share verbally. So the topic is clear. I will prepare myself until. Yes, okay, well done. Mrs. Lisa. Maybe swelling. Okay. Don't forget the steroid, one of the management plan. However, it's one of the possible causes. So it's a cause, and in the same time, it's treatment. Plus the medication you mentioned, acetazolamide, topiramate, sometimes it helps. Plus the surgical option, which we mentioned or you mentioned, recurrent lumbar puncture, along with the VP shunt. Okay. Okay, we can start.
Okay.
Hello there. I'm Dr. Mukhtar, the doctor in the clinic. You must be Mrs. Lisa.
Yes, I am doctor.
You are 35.
Yes, doctor.
You're 35 years, yes. Okay. We are here to discuss your health issue. Is that okay for you?
Yes, please, doctor. Yes.
Okay. I read that you have some swelling in your leg. Can you tell me more about that?
Yes, doctor. I have noticed this leg swelling for the previous 2 to 3 days.
Okay. And is it on one side or both side?
Yeah, it's my right leg, doctor.
One side. Okay. Is there any pain?
Yes, doctor. It's painful.
Where exactly the pain?
In the back of my leg, doctor.
Any trauma before?
No,
Okay. And the pain travel or goes up or distally to the toes?
no, doctor.
What the nature of the pain? Is it electric shock?
Uh, no, it's like dull aching.
Okay. And the scale from 0, no pain, and 10 is the maximum pain scale. How much you can scale your pain?
I think 7 to 8, doctor.
Are you in pain now?
Yes, doctor.
Do you need some painkiller?
Yes, please.
Okay, here you are. You can take this painkiller. Are you okay to proceed?
Yes, doctor. Yes.
Okay. Apart from this, do you notice the swelling leaves mark when you press on?
I think so, doctor. Yes. My socks is leaving mark.
Okay. Did you notice the swelling going up?
Um, I'm not sure, doctor, but I think yes, the swelling is from my legs up to my thigh. Yes.
To the thigh?
Yes.
Any color change?
Um, no,
Any skin rash?
no,
Any oozing?
no,
Any sores?
No.
Okay. And you told me the pain is down, not going up.
Yes, it's more in my leg, doctor. Yes, in the back of my leg.
Okay. Apart from this, you is it a previous time in your life?
No, this is the first time.
Okay. Any travel history recently?
No.
Okay. Any family with the same condition?
No, doctor.
Okay. Any infection recently? Anywhere in your
Uh,
body?
yes, doctor. I had this chest infection about 1 week ago, and I was in the hospital, doctor.
Okay. Any cannula or any catheter was inserted in your feet or your right leg?
No, doctor.
Okay. And for this chest infection, what medication you received?
I think they gave me some like IV medicine for it, doctor.
Do you
Some,
remember the name?
I think ceftriaxone.
You have any allergy to any medication?
No,
Any surgery before?
no.
Any past medical history I should be aware of?
Yes, doctor. I had this problem in my joints, rheumatoid arthritis, for the past 6 years.
6 years. Are you controlled?
Yes, doctor. I have been taking my medication and it's okay now.
Okay. What medication you are taking for rheumatoid?
Yeah, I'm taking some painkillers and I'm taking methotrexate.
You are compliant to both.
Yes, doctor.
What painkiller you are taking?
Paracetamol?
That's it? Or any over-counter medication?
No.
The methotrexate regularly you are taking?
Yes, doctor.
When you have the infection, did you stop the methotrexate?
Um, no, doctor.
Okay. Are you taking the medication for anemia called folic acid?
Yes, doctor. Because
You
of
are
my methotrexate.
yeah, okay. Apart from rheumatoid, you have any other condition or disease I should be aware of?
No, doctor.
Okay. And you have any weakness or pins and needles around this leg?
Uh,
Any weakness?
no, no, doctor.
Any pins and needles?
No,
Okay. Any headache, Mrs. Lisa?
no, doctor.
Any blurring of vision?
No,
Any redness?
no.
Okay. Any chest pain?
Um, I think so, doctor. Yes. You know, there is like these pins come and go to my chest, like pins, like it's pins and needles in my chest.
And you feel any awareness of your heartbeat?
Yes, doctor. Yeah, I feel I have racing of my heartbeat.
Is it regular one?
Yes, doctor.
Is it fast or slow?
I feel it's fast, doctor.
Okay. Uh, you have any problem with the breathing?
Yeah, I think with this pain that comes to my chest, I have this problem breathing.
Okay. And the pain only in the middle or in both sides?
Uh, no, it's more much. It's both sides, doctor. Yeah, it's like pins, like this pins and needles in my chest.
Okay. You notice skin rash over your chest?
No,
Any cough?
no.
Any coughing up blood?
I think no, doctor. No,
Any noisy breathing?
no,
Any difficult swallowing?
no,
Any change of bowel habits?
no,
Any tummy pain?
no,
Any change of the water work?
no.
Okay. You have any raised body temperature
No, doctor.
and any night sweat,
No,
lumps or bumps in your body?
no.
How's your appetite?
It has been going bad for the last week, doctor. Yes. I can really feel myself not eating well.
And any change in the weight?
The past week, yes, I lost 2 kilograms in my weight.
Okay, I'm so sorry about that. You're feeling thirsty, Lisa, Miss Lisa.
No,
Okay. Any dizziness?
no, doctor.
Do you smoke?
No, doctor.
Do you drink alcohol?
Only social, doctor, in the weekends.
Okay. What's your job?
I am secretary, doctor.
And that affecting your job?
Yes, doctor. Actually, after I was discharged from the hospital, I couldn't go to work.
Okay. Did they diagnose you with a chest infection?
Yes, 1 week ago, doctor.
And you stayed in the hospital for how long?
I stayed for 3 days, doctor.
And after that, you feel better.
Yeah, my chest is better, doctor. Yes.
Did they send
Fine.
for yes, did they send for phlegm for a swab?
Um, I think yes, doctor. I think they said that they will start this antibiotic and they will send some phlegm. But
Okay.
that time, I after the antibiotics, it's better, doctor.
Okay. Do you think this chest infection coming frequently or first time?
Actually, this is the first time, doctor.
Okay. Did you notice any eye swelling or swelling around the eye?
No.
Okay, I may examine you.
Yes, please.
Starting by the general look, how the patient look. Is she hectic,
No.
looks toxic, pallor, jaundice,
She looks ill.
looks ill. Okay. The vital chart, blood pressure, temperature, and pulse rate.
All right. Uh, temperature 36.5 and pulse rate is 120. Blood pressure is 150/90. Respiratory rate is 28.
Is she known as a hypertensive patient?
No.
Okay, now I'll examine for the pallor or anemia in the hand, any clubbing,
Negative. No. She has
any
some rheumatoid changes in the hand.
okay, any signs of infective endocarditis, splinter hemorrhage or
No.
January lesion. Okay, I will
No.
examine the joint now. Any activity of the disease?
Uh, no. Only rheumatoid chronic changes.
Okay, no activity, no effusion.
No.
Okay, the function of the hand,
Uh, a little bit limited. Just a little bit.
any deformity,
Just more. Yeah. Just chronic rheumatoid. Just small swelling in the little fingers.
okay, and any carpal tunnel signs.
No.
She can pick a coin.
Yes.
Okay, any proximal myopathy,
Yes. Possible.
proximal myopathy. Any tightness of the skin?
No.
Sorry for this question, Miss Lisa. Do you have any problem with the period?
Mm, no, doctor. My period was okay.
Any miscarriages before?
No, doctor.
Are you on birth control pills?
Uh, yes, doctor.
Okay, you have a regular partner
Yeah, I
or
have a partner, doctor.
you have any casual relationship?
No.
Okay. What's your diet? Or how about your diet? Is it a balanced diet?
Yes, doctor.
Okay. I will examine now the ankle, the right ankle.
Yes.
The color first. Any redness?
No.
Any deformity?
No.
Okay, the feeling above it, any high temperature, any hotness,
No,
any nodule,
no,
and the edema extending to the thigh.
yes,
Okay, any sorts of or wound or infection site,
no,
any insect bites,
no,
Miss Lisa, recently.
no.
Okay, now I will examine the chest for interstitial lung disease,
Uh, no crepitations.
no crepitation, and any increase in pulmonary pressure, signs of
Yes,
increased pulmonary pressure,
yes, positive.
positive.
Yes,
Any change or signs of heart failure?
no.
Okay.
2 minutes.
Yeah, Miss Lisa, may I know what's your concern?
Doctor, what caused my this swelling in my leg?
Yes, I appreciate your concern, Miss Lisa. Uh, Actually, we have many possibility for that since you have rheumatoid arthritis and you are on medication to suppress the defense system. You might have infection inside the ankle. We should roll it out and we should admit you now to run some workup. And we might need also to get a snip from this joint. Apart from this, we have to think about other possible causes. You have any other concern?
What about this pain in my chest, doctor? What should I do?
Yes, I appreciate your concern. We will also consider that in our plan. We will have our a group of specialists, including the chest doctor. It might be something serious, and we should also run some work up for that. I'm afraid to say it might be a clot inside the blood channel of your lungs. So for that also we have to run some workup. That okay?
Yes, okay, doctor.
Okay. Any other concern?
No, doctor, thank you. Time is up, yes.
Mhm.
What's your diagnosis?
Yes. Actually, no clear diagnosis for Miss Lisa. She's 35 years. Came with complaint of leg swelling, and it's only one side, in the right side. It's pitting edema. Supposed to measure the circumference of
Yes.
the leg. Yes, I missed this one. However, there is also pain in the scale from 7 out of 10. The pain is dull aching,
It's
and
the back of the leg, in back of the leg, back of her leg,
the back
on
of the leg. Yes,
in the calf muscles area. I- I'm
calf
sorry,
muscle.
yes. Yes, the
Yeah,
calf, back of the leg, back of the leg.
yeah, yes, it's yeah. I thought it's down a little bit. That's
No,
why
no,
I
no.
was confused.
Once you said ankle, I understood that
You
you
corrected? Okay.
back on the leg. Yes.
Yes. Okay. So apart from this, she has chest pain, palpitation also. Uh, on examination, there is signs of increased pulmonary pressure, on the and she has also she had history of chest infection 2 weeks back, for which she received antibiotics. It was ceftriaxone. She's known rheumatoid arthritis patient since 6 years on methotrexate, and she's compliant to the medication. Some painkiller for the joint or rheumatoid arthritis activity. Apart from this, she has no travel history, no family history of same condition. On examination, Miss Lisa has some activity of the disease in the hand in the form of uh, swan neck deformity. The function is still preserved. There is no other signs of activity in the hand. After examining the legs, the swelling or the edema is pitting one, extending to the thigh, and the pain also at the back of the calf muscle. So on top of my differential, for the tachycardia also and the palpitation, I should put in my differential DVT
Yes.
and to investigate for that, for the seriousness of the condition.
Yes, that's
Ha-
right.
However, and CTPA at the next step. The second possible differential in this patient will be Becker cyst, ruptured Becker cyst, due to also the disease, rheumatoid arthritis. Septic arthritis, if the pain is at the ankle, which I thought earlier, but it's not
Uh,
at the ankle. Yeah,
no, it's the back of the leg, doctor.
yeah, but so yeah, the differential will be changed here. It was mistaken differential for me. However, if the ankle is involved, we have to also to investigate for septic arthritis. Since the pain away from the ankle, so I could think about DVT and PE. The second differential Becker cyst or ruptured Becker cyst due to rheumatoid arthritis.
Yes. What do you think the cause of the DVT in the patient?
The stay in the hospital the last week for antibiotics. Maybe she was immobilized, and also she is non-rheumatoid, immunosuppressed on methotrexate. Maybe the side effect thromboembolic event.
Mhm.
Yes, I rolled out. I asked for the history of any cannula or catheter in the leg.
Mm.
It was out. No trauma as well. No travel history. So
Okay.
the only risk factor in this patient, immobilization in the hospital for the last admission.
Yes. Okay. How do you investigate these patients?
Yes, starting by baseline basic investigation, routine blood test CBC for anemia and leukocyte to rule out leukocytes if suspected infection. Inflammatory markers, CRP, SR, D-dimer specifically for this patient. However, it will not be good. It's good negative test, but it's not specific for the DVT or PE. Rheumatoid arthritis antibodies to be screened for, including the rheumatoid factor and anti-CCP antibodies, and also other autoimmune screening like anti-nuclear antibody and other screening for autoimmune disease. For the condition here, I could start by DVT screening Doppler in the leg. Apart from this, I can do also Doppler to the knee or the calf if I suspect ruptured Becker cyst. But still, the serious here, we should roll it, is the DVT and complicated PE. Since I suspect PE, I should consent for CTPA and proceed for CTPA, and we'll start anticoagulant immediately till we confirm the diagnosis.
Okay. How do you treat these patients?
Yes, in the acute state, if PE is suspected, ABCD approach, we should start with circulation, hemodynamics, and breathing, airway, and saturation vitals. If the breathing is affected by any way, we can consider intubation. If hemodynamics also affect or compromise, we could think about thrombolytic therapy instantly. However, we have to have the multidisciplinary team approach, including the cardiologist, pulmonologist, rheumatologist, and clinical pharmacists, also social worker and GP, specialized nurse, physiotherapist, respiratory therapist.
Uh,
Apart from this, the treatment of the underlying cause for the rheumatoid to control the rheumatoid arthritis by the MARDS medication and yes, painkiller for for the pain, and echo also to be screened for cardiac function.
okay. Um, Thank you, Dr. You did well. I'm not sure why. From the beginning, I think I said back of
Yes,
the leg. I'm not sure. Because I think some miscommunication happened.
yes,
But
I put the pain
back of
down.
yes,
But
back of the leg. I meant like in the area of the calf muscle. But because she's a patient, she cannot. I think you have to tell her, show me where is the pain.
yes,
Yeah.
yes,
Uh,
you're right.
sorry.
No problem. Yeah, but sometimes the mistakes clarify the communication and to prevent further mistake.
Yes.
So yes, whenever I had this mistake here, I suppose I will learn from it. So also my mistake not to ask where is exactly the pain and what you mean by the back of the leg.
Yes. Yes. That's right.
Yes, supposed to ask the level exactly and which joint. w- Although I ask you where is the exactly the pain and you told me it's going down, I think. So
No, no,
I
going
thought
up, up.
it's
The pain is
going
going up.
pain
It's
going
extensive.
up.
It's supposed to be extensive DVT, and it's coming from the back of the leg and going up to the thigh.
But as DVT per se, it's not painful as we know, as I know. It might be painful, but the commonly it's not painful. So I
Uh,
thought it's ankle problem or joint problem. It's
ah,
okay.
no, no, but DVT, most of the patients I see has painful legs, or any painful lower limbs, most probably.
Unless there is thrombophlebitis, it will be painful. Other than
Ah,
this, it will not be. It's just be swelling. And some patient didn't notice also there is swelling in the leg unless you measure the circumference that time
ah,
only. You can
okay,
discover, yes.
okay.
Anyway, it's nice case. And
But yeah, but I think I'm not sure. I think deep vein thrombosis can have leg pain. I think, and that's why I said pain.
mm, no problem.
Can
Yes,
I comment on this, please? Because I
yes,
had a similar case in my exam.
yeah, sure.
So, uh, uh, first of all, with the chest pain, you did not really analyze the pain, did not ask for the character, the severity increases with rest or with exertion, with leaning forward
Mm-hmm,
to know that it is pleuritic chest pain.
mm-hmm.
So this would have helped a lot. And with the dyspnea as well, and also the chest pain, you should have asked, did it come before or after the leg swelling, so that you could relate both complaints together. Okay, and about the pills, you should comment on this. That she should advise her to stop the pills and to refer her to the gynecologist to change the method of contraception. And what else? Yes, about the pain in the leg for DVT. My case in the exam, the complaint, it was lupus with the antiphospholipid syndrome, coming
Mm-hmm.
with shortness of breath. And in the history, she said that she had also leg pain. And so it was, so they were all interconnected, if you know what I mean. So
Yes.
yes,
So
the
the
DVT
same.
can present with pain, yes. So don't just ignore it. Yes.
Mm-hmm. Okay. Yes, maybe
Yes.
the localization, it was my mistake. And that's why I drive the
Mhm.
scenario in other way. It's septic arthritis, gouty arthritis, and the chest pain like pleurisy, not PE at all.
Mhm.
That's why. But at the end, when I realize the pain is at the calf or at the swelling at the calf muscle, that time
Yes,
only
it comes clear. Yes.
yes, yeah, that's it.
Mhm.
Thank you, Dr. Yasmin, for your comment and for your
You're welcome.
experience.
You're welcome.
Okay, thank you. Did differential again? Yeah, it's clear now the differential will be DVT and PE and ruptured Becker cyst as a complication of rheumatoid. You might add also as unilateral swelling. We can add cellulitis, and this is the commonest cause of unilateral leg swelling. DVT and in this patient, rupture Becker cyst and cellulitis. But again, cellulitis, no any signs of infection, no redness.
Sometimes
Sorry,
hemoarthrosis also comes.
What?
Sometimes hemoarthrosis, like in hemophilia.
Yes, but it will be localized to the knee. Yes, I
Yes,
agree.
but
Yes.
you know, in the complaint they say leg pain, and then you have to ask specifically where exactly in the leg, and then you would say in the knee, and then you keep analyzing until you, because they will deny trauma, because with hemophilia, it could be very minor trauma that the patient cannot remember. So you ask about trauma, he will say
Mhm.
no. But if you keep asking with the history, he will say, for example, he has bled before from his nose, from his he bruises easily, he gets blood transfusions, and so from the history you can catch it is hemoarthrosis. And in this case, it is contraindicated to do aspiration.
Yes, of
Because in
course.
any joint swelling, yes, aspiration is
Yeah, he will
okay,
he will
recommended.
bleed more.
Yeah,
Yes.
yes, exactly.
Plus, he will be male rather than being female because it's X-linked disease.
Yes, exactly. And maybe there is a question about the inheritance.
Yeah,
If
X-linked.
his
X-recessive.
children can get it, and
Yeah,
no, he
male
cannot
to male.
pass it. Yeah.
Yeah, male to male
Mhm.
inheritance. Yes. Thank you, Dr. Yasmin. Actually, the confusing point in this scenario started the complaint as swelling and ended the scenario as pain.
But
Yes.
DVT has to come with pain, doctor. Yeah,
Yes,
most of
yes,
cases of
I agree now. Yes, okay.
most of cases of DVT can come with swelling, with pain. Actually, they can come with signs of cellulitis also. And it can be
Yes.
associated redness, hotness, everything. But
So
the pain and
I should analyze the swelling and the pain more. Where exactly the level and the local, exactly the area of the pain, the maximum intensity.
yes,
Because I
Um,
couldn't localize it, that's why I was lost. Yes, sure.
And also about the chest pain. In
Yes,
the
I should
exam, they
also analyze. Yes.
yes, but in the exam they asked me, could this pain be cardiac? And so this got me a little confused, and I said could be pericarditis
Yes, exactly.
because it was increasing with inspiration, so it was not like angina pain or
Mm-hmm.
if you get what I mean.
Pericarditis and pleurisy, the same.
Pleurisy
Right.
or pericarditis, yes, but they
Yes.
asked specifically if it could be cardiac, so I said could be pericarditis, but in
Could
view
be,
of the history, it
yeah,
is more like
ischemic heart disease.
a pulmonary embolism and stitching pain of pulmonary embolism.
Yeah, and it might be also coronaries. If the pain also heaviness, it might be atherosclerosis complicating the rheumatoid. It might happen.
But the coronary will be, if you analyze the pain, it will be
Yes, of course,
heaviness
different.
and
Yeah,
yes,
with
yes.
exercise, and it will not
Mhm.
be. It will be
Yes,
heaviness.
exactly.
The
Mhm.
character will be changed. Yes.
So
Yes.
the analysis of the pain, of the chest pain, is very important.
Yes, you're right. Yes.
Mhm.
this patient, yes, was with tachypnea and tachycardia both. And if you analyze the chest pain, it will be at rest, not related to exercise. And there was no signs of heart failure. So yeah, it was going more with pulmonary embolism, and there was signs of pulmonary hypertension. So this is going with pulmonary embolism more than ischemic heart disease.
Yes.
Mhm.
Yes. Thank you, Dr. Sarah, for the case. Thank you, Dr. Yasmin, for the comment. Let's
Thank
read the
you.
other comments. Yes. Thank you.
Okay. Sorry. Yeah, we have to, for this case, but I wanted to comment one comment
Yes, sure.
that, or two comments, sorry, for this patient. You have this is the work of the DVT. You have to check if it's provoked or non-provoked. In this case, she was provoked, but we cannot rule out other unprovoked cases. We have also to run tests for the thrombophilia.
Abla test, yes. Antiphospholipid antibodies.
Yes, either the also we have to ask about the hereditary thrombophilia. Even if the patient is rheumatoid arthritis, also we have to ask about hereditary thrombophilia. About the examination, we have to check the circumference of the calf muscles bilaterally. The most important thing about the management of this patient that she has chest pain and she was dyspneic, she was tachypneic and tachycardic. So this is some people will start with the ABCD protocol, like check airway, check breathing, and then directly admit to the ICU and start anticoagulation, even by suspicion, because the Wills criteria here will be high. That's it. The examination of the examination of the chest and the vital signs and the lower limbs is the most important part in these patients. Regarding the examination of the hands, I'm not sure. I hear that
postpone.
You can postpone and you can only examine if there is activity or not. No need for the deform, not to go full, only if there is activity or not.
Yes, you're right. I agree.
Also, the examiners asked me about the pills. If I mentioned to the patient that she has to change to another contraception, and the examiners asked me, "Will this be for forever or temporarily?" I said forever, and apparently it was correct because I did not lose. I got the full mark in this scenario. So. But honestly, I don't know when is it temporarily and when is it for life. But in this case, it is for life. Okay, so it was. She had
whenever the patient has risk for thromboembolic condition, you have to stop any trigger. One of them, the OCP.
But forever or until.
Yeah.
Or for I don't know how long.
What do you think? Yeah, forever, of course.
This case of pulmonary embolism. So
it's thromboembolic event.
Yeah. So anticoagulation will be for life, and also I think stopping the precipitating all the factors that can lead to PE should be considered.
Yeah, I agree with your answer. Lifelong. Stop or switch to another way.
Okay, and if she becomes pregnant, for anticoagulation, she will take low molecular weight heparin.
Yes, exactly.
And that pregnancy should be planned. And so all these are things that you should, I was asking them in the examination, and you should mention it to the candidate as well, the surrogate, I mean. And one last comment, if the complaint is leg swelling, then it's the best that the first thing you examine is the leg, because this is the presenting complaint. So that
yes, you're right. Yes.
Yes. Okay. Just
you're right. Yes,
all the comments that I get.
Thank you, Dr. Sismin. Yes, I'm supposed to start with the ankle itself or the leg swelling. Sorry, I'm still insisting for the ankle, for the leg swelling. Yeah. So whenever you have complaint, try to start with, but always I'm starting with the vital charts. However, just to skip the rheumatoid now, you can do it if you have time later, because also you have very important system to check or to examine, which is cardiovascular and respiratory. Then if you have time, yes, we can do the hand. Yeah, I agree for all these comments. Thank you, Dr. Yasmin and Dr. Sarah and others for your comments.
Communication, Dr. But yes, I think also for me, if I think I can, the best communication happened because the site of the pain was not.
Yeah, especially we are in online sessions, so whenever I will see the patient, the situation, the situation will be different at all. So it's okay. We are learning from the mistakes, and
that's why it's important to ask to see the patient first thing in the.
Again, we can repeat this. Whenever you start the session and you sit with the surrogate, you can have a look to the patient. Patient will be sitting on the chair or on the bed behind the curtain. No problem. You don't hesitate to ask to have a look for the patient. especially if there is something pathognomonic like rash or swelling or redness. Something can show, like also SLE rash or any rash in the body. You can ask permission to go and to check the patient. This is what I heard also from a candidate. You can do that. Not only sitting to the surrogate taking history. No, you can do whatever you want in your 15 minutes. After the 15 minutes, you will not be allowed even to look to the surrogate or to the patient. So it's good advice to have a look to the patient, and after that, you can continue your history. Whenever you are done with the history, try to do the examination as soon as possible, because also you might miss a lot of things if you didn't examine the patient. Okay. Okay, I think we're done with these two cases today. Thank you all for listening. Thank you for sharing and commenting. Thank you, Dr. Sarah, for the case and for the practice. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum salam. Bye.
Right.
Yeah.